How does evidence-based medicine help with this value discussion? Can we leave it to the evidence-based medicine community to solve this value discussion for us?
I'm going to sit forward here. You know, it's supposed to be a fireside chat, and so I feel like I should start by saying, hi, my name is Ken, and I love evidence-based medicine, because I'm a bit of an EBM nerd. But I want to make sure that you understand what I'm talking about when I say evidence-based medicine, because EBM means different things to different people, right? And most of the time when I say evidence-based medicine, it might mean something different to the government, to the innovator, to the patient advocate, or to the physician. And most of the time when I talk about EBM, people think, oh, it's about the literature. And you know what? It's not. So I want to bring people back before we start. I want to bring people back to the early 1990s. So this is a bit of a time zone thing. Doodle-doo, doodle-doo, doodle-doo. Okay, 20 years ago, okay, Dave Sackett said, evidence-based medicine is the conscientious, explicit, and judicious, those are big words, conscientious, explicit, and judicious use, not of just any evidence, but patients want the best evidence. And physicians do it. I don't see populations. I treat one patient, one at a time. And so I want to make individual choices based on the best evidence. And the only thing I'd add to that definition, it should be shared decisions, because most of the stuff we do in medicine, there is a lot of answers, not just one right answer. There's lots of right answers, but the patient needs to be involved. And so when you think evidence-based medicine and how we're going to do it and how I do it at the bedside, is I think of it as a Venn diagram, and you've got the patient and their values, expectations, and desires, my knowledge, skills, and attitude towards that, and my abilities, and then the literature. And it's the literature that guides me and directs me, and that evidence helps me provide value to that patient. But that patient isn't going to remember a p-value of 0.001, and they won't remember a confidence interval ranging from this to this. What they're going to remember is how I made them feel. And so I use the evidence to guide my decisions, to make shared decisions for individual patient choices so they get value out of the research that's being done. And there's a problem, because it can take 17 years for high-quality, clinically relevant information to reach the patient's bedside. I've been practicing for 20 years now, so right now I'm about 3 years into my training. Because I was taught, right? 17 years for that information, that really good stuff, to reach the patient. 17, and it's not for 100%, it's for 14% of that high quality, clinically relevant information to reach the patient's bedside in 17 years. And we can do better than that. Thank you.
Thank you.